that's what we'll be talking about before we go to the phone lines. And so I'm going to throw it open to Dr. Akinsete and tell us what there is for us to know. Yes.
Very good. Thank you, Thelma. I think over the past weeks we've been talking about sickle cell and perhaps the individual, how it affects the person. We've set the stage in a few episodes describing what sickle cell is all about. So we've established that it is a disorder of the blood that is inherited. It has a lot of complications. It has social, cultural implications. It's associated with stigma and discrimination. There's so many aspects to sickle cell, but we've been talking mainly about the patient, about the individual. But today we're going to be focusing on public health. And people may be a little confused. What are you talking about in terms of public health? Public health is not talking about community. How does sickle cell affect the community? How does sickle cell affect the population?
Right.
What population strategies are there to be sure that we cage this condition, that we bring it to heal? And when you talk public health, you also talk about what government is doing, and what programs are there in place, what policies are there, what strategies are there, things like that. So that's what we'll be discussing today. So the first off, you want to say, yes, so what has government done? And I was privileged to be in a meeting with government last week in Abuja, and we did talk about it. We said, government admitted that. When I say government, that's the Federal Ministry of Health, because really they should give us direction and focus, give us
support.
They don't say support; it's a little vague. But let us have something articulated in on paper that this is the policy for sickle cell in Nigeria. Okay. So when we are looking after a person with sickle cell, these are the things A, B, C, D that should be done. Okay, that's it. Then there should be plans. Then at what levels, what treatments should be given, who should give these treatments. All should be articulated on paper.
Okay.
So we asked where, and they said there were policies. We said, where are they? So if you come up with policies, you should disseminate them. Let them be everywhere, not just staying on the shelves.
So you're saying there are actually policies that actually exist?
Yes, they said there are policies on sickle cell.
That you're not aware of.
I may know, but so many people do not know that they are there. So indeed, they talked about their challenges that are not able to disseminate these policies. But so people are a little confused. Where do we fit in? So I said we had discussions about if government is unable to do it, there are non-governmental actors who can step up to the plate, like the Sickle Cell Foundation Nigeria, many other NGOs who are not for profit who can work. So all we need right now is put out those policies there, and we will do the legwork for you. So that is as far as that is concerned. But then we go on and say, what is in terms of public health aspects? We're talking about the public health principles and practice and strategies that's come into play in the sickle cell space. Okay, we dispensed a little on the policies, but then we talk. What about strategies? What do people do? What do you want contained in that policy? Do you want there to be a law on sickle cell? I'm sure you've heard about things like that. There are some states in Nigeria that have gone on to I think they're stages of bills. They're passing bills in their assemblies that will preclude persons who are carriers from coming together to have a child, either married or not. So in fact, they're proposing criminalizing persons who have come together as a couple, even when they know that they're carriers. So they're insisting that they must have their tests done, and if they're carriers, that is their AS and AS, they must not marry. If they do, they are going to be penalized in terms of it's a criminal offense.
Isn't that a little too extreme?
So many. So of course it's very controversial. There are those who, and you don't believe it, Thelma, those who are pushing for this happen to be persons who have the condition. Warriors, as we call them, persons with sickle cell. But then if you can also know where they're coming, you can tell, understand. One can empathize because they don't want this to happen to a child of theirs. They don't want to bring a child into this world that suffers what they are suffering, because they have asked their parents questions. Why did you do this to me? And all that. So, but anywhere in the world, it's empirical. There's empirical evidence. Any genetic condition, you just don't criminalize. What it does is that it sweeps the condition into the closet, and you can't really deal with it. You need to bring it out in the open. We'll talk about it. But the thing you should do about such conditions is genetic counseling.
Right.
So when we talk public health, we talk prevention. prevention at different levels.
Right.
Okay, and the first level of prevention is what we call primordial.
Primordial.
And that is...
Okay, before you go into that, let's just see who's out there. There's been a call that's been pending. Hello, good afternoon. Hello, are you there? Okay, do try to call us back. We lost you there. Apologize for that. The number is 0700 923 923 923.
Primordial, primary, secondary, tertiary. That's the way we categorize them.
Okay.
Primordial is like the very basic. You don't even want that S gene, sickle cell gene, in the population at all. But it has happened. We can't do anything about that. It is here. It is with us. Like I said, in medical history, it has it that it was a mutation. It came up from nowhere. Nature's way of trying to make sure that the species survives. Because that S gene combined with the A gene is protective against malaria. And it was seen at the time that AAs, those who have the normal hemoglobin, tended to succumb to malaria, whereas those who are carriers were resistant to malaria.
Okay, just hold that thought. Hello, are you there? Good afternoon. Good afternoon, sir.
Complication of sickle cell. So it looks like this is something your son has been dealing with for some time. If he's a young adult, I assume, if he's getting into university. But the thing to do is he must see his healthcare provider. He must see his doctor. The good thing is that University of Lagos has a fantastic system, and they have a beautiful program for sickle cell. He may not be aware, so he needs to just walk in to their health center and ask, and let them know immediately that he's someone who has sickle cell, and they'll register him, and he'll be on their management protocol, so they know what to do. Don't prescribe for yourself. Sorry, don't prescribe for your son. I don't know what that medication is you're talking about.
You've never heard of it?
No, I haven't.
Okay.
But there's so many medications out there that are dubious, quite frankly. So the best thing is for him to see the doctor at the health center in Unilag. They have a beautiful program for sickle cell control. Okay. So please do that, Mark.
There's a policy there that's running and functioning.
They have a good program.
Okay. All right then.
Yes. So we were talking primordial. I think we dispensed of that because we said that we already have the S gene in our population. But okay, the next level is that now primary prevention. How do you prevent a child getting that S gene? So the only way is this thing I said is called genetic counseling. People and even before that, people need to be aware. Another public health practice or principle is raising awareness in the public through any medium. This is something we're doing. What we're doing now is part of it, but we can also, key in on social media, all the platforms. But and more importantly, it's also part of what should be articulated in government policy. This policy, I'm not saying government should do it, but it should be part of policy to say that maybe all media houses need to talk about sickle cell. If it is policy, then it is something I have to do. Okay, and besides that, there have to be actual intentional outings to communities to raise awareness, to talk to the people, rural and urban slums. We find that there are more people there. So, and in schools, so actual intentional activities that you go out and talk about sickle cell, tell them about it. What's the causation? Tell them it's not infectious. That's another important part of public health aspects. Because we're talking population health. Do not worry that you are engaging or closely in contact with someone with sickle cell. You're not going to catch it. It is hereditary. So all that information has to be put out there in population basis. Wherever you have people in connections, churches, mosques, go out to the communities, and what is this is it's important to articulate this as a policy. Otherwise, nobody would do it. If it's a policy, it is who does it, what is done, where is it done, and so on. Otherwise, nobody will do it. Okay, that's in terms of prevention. Primary, that is, how do you make sure people don't get it? And that happens because it's not written on your forehead. You need to do tests. So when you raise awareness, you've talked about it, the causation, people have to be tested. And it's expensive. So again, that's why government policy is important. If government says this has to be free, then it's free. Because this government has, they're able to wield their big stick, and they need to come in and do that. That testing is important. Without testing, you cannot know that you are a carrier. And that's where the problem really lies. Those who have the condition have symptoms, so they know. But if you're a carrier, that is, you have the trait and you're well, you can't know. So you need to have a test done. What we are doing now, National Sickle Cell Center, the Sickle Cell Foundation as a whole, is to target young people in schools. So we get them, so they know their genotype, they know what they are whilst they're young, before they get into relationships.
Okay.
We want to ask another question.
No. So there is a call. I'm trying in between what you're saying for us to just go on.
Let's get the question.
A call and then a break. So I think I made my choice. We're gonna go on the break. When we come back, perhaps we'll be able to pick some more calls. 0700 923 923 923, and we'll look at other aspects of public health as it concerns sickle cell disorder. Don't go. We are back. It is 2 minutes before it turns 1:30. Yes, that is 2 minutes before 1:30. You're still listening to Surviving Sickle Cell on your number one family radio 92.3 Inspiration FM, a show in partnership with the Sickle Cell Foundation Nigeria, with the national director with us in the studio, Dr. Annette Akinsete, with whom we have been discussing public health aspect of sickle cell disorder. Did you know that yes, there's actually a public health aspect of it? Sickle cell disorder as it affects the populace, what we need to know, what we need to do and shouldn't do. And then we went as far as talking about laid down policies of which the federal government says, well, there are, which a lot of us are not aware of. And what do you think about this? Apart from that, you can also be a part of a conversation. You can call in and tell us, express your fears and concerns about what you know or probably are not sure about sickle cell disorder on the number 0700 923 923 923. Or if you do have questions indeed pertaining to what we're talking about, that is the public health aspects of sickle cell disorder, you can also get your thoughts through to us. On our WhatsApp platform, the number is 0817 313 6193. Only questions on that, no calls. Primordial is what we went through with what?
Primordial we've done.
Yes.
We've done primary as well. Primary is, okay, we don't want that gene to now come. We don't want couples to have a child with sickle cell.
Right.
Okay, and that's by genetic counseling.
Right.
And testing.
And even as a carrier.
You must do the test.
Mm-hmm.
So you know whether you're a carrier.
Okay.
And if you're a carrier, you're now able to make an informed decision whether to have a child with another carrier. Because if you do that, you have
whether
one in front.
Or not to.
No, you can't say not to. You can't compel people not to have children.
Right.
But I think I've shared it on this program in the past.
True. Yes.
That there's empirical evidence that 80% of those who are counseled properly will not go on and have children together.
Okay.
But there will still be that 20% that will, despite everything
not
you
go
say,
on and have children together.
they will not.
But could get married.
They will not. Well, they will not have children. They will go their separate ways, or
Okay.
if they opt to marry,
Okay.
they have other options. They may adopt and do other things. But the people usually fear that we're maybe encouraging persons who are carriers to have children. We're not encouraging, but we cannot compel persons not to come together and have children. The thing to do is to be sure that they're exposed to good genetic counseling.
Okay.
And that when that is done, 80% will not have children. With something, they'll go their separate ways and find another partner. But there will be that 20% that will have children together, marry and have children together. So we would still look after those ones. So anyway, that's primary prevention, preventing the next generation from getting the gene.
Right.
That is, don't have children with sickle cell. How does that happen? Is genetic counseling, informed decisions. They will go their separate ways or otherwise. If they go on and have children together and someone has sickle cell, then it has to be diagnosed early. How is that? We call that in public health principle or practice, prompt early diagnosis and prompt treatment. If you diagnose early, the best way to do that is what we call newborn screening, which again we have asked government to be sure it is captured in their policy. Newborn screening, that every child that's born in Nigeria must be screened for sickle cell. They do it in America, they do it in the UK, where they have an infinitesimal amount of sickle cell compared with us. But every child is screened for sickle cell among other genetic conditions.
Okay,
we
correct
want that
me
to
if
happen
I'm
here.
wrong. I think I remember one of the episodes where you had said, or one of the doctors, that the sickle cell trait doesn't exactly show at the very early stages. So
Okay, it's not even trait. Sickle cell disease or disorder. You can't. It's not clinical. It's not evident. Clinically.
In the very early days.
Until about 6, 7, 8, 9 months.
Okay, so when you you have a baby, you should try to find out or
by doing
detection.
That test. It's called a screening test. There's a special test you can still use to detect that sickle cell in that child.
Even when your baby's younger than 6 months?
Yes, it's a special test. It's called newborn screening. It's more expensive than the usual tests. The usual tests will not detect it for you.
Okay.
Because there's what they call fetal hemoglobin.
Okay.
The type you have in your mother's womb. That's the type that kind of overshadows what the child has genetically. But at birth, there are tests that you do. We use they call it the machine uses it's called HPLC machine. There's no need to talk about that here.
Yeah.
But it can be done in early infancy. Is in neonates, newborns. That's why it's called newborn screening. It's done everywhere. I know that in Ghana they've started a program on newborn screening for sickle cell. We want to do that in Nigeria.
Okay, so what is this early detection? What does it do?
Once you find they won't reverse.
Okay.
Once you find out in time, we've passed that primary prevention.
Yeah.
Now you detect it in this child. You must treat quickly, and that's the secondary prevention. You're preventing. I give you that statistic that's abysmal. That out of 150,000 babies that are born in Nigeria every year with sickle cell, 100,000 do not get to the age of 5. And what kills them is infections. Okay, so once you get that, detect that they have sickle cell in infancy, neonates, newborn, first 1 month of life, you quickly institute preventive measures of antibiotics, special antibiotics, and special immunization that prevent those infections that kill them before the age of 5. Once you prevent those infections, they make it to 5. And once they make it to 5, they make it to teenage years. So they see it's so important to catch them early. So it's early detection and prompt treatment. And this treatment here is preventive treatment. That brings us to second level of prevention. They already have the condition, but you're preventing complications that kill them from setting in. You get my point. So now we move on to the tertiary prevention.
Okay, before we move on to the tertiary, because you already rightly said that, for you to detect it in, an earlier stage, earlier than 6 months, the test is different, it's unique, and it's quite, expensive. So to be fair, for those who cannot afford it, what can they do?
It's not individuals, it's public health.
Okay.
So it's government's responsibility,
right?
To be sure that it should be a policy that in every hospital where a child is born, that child should be tested for sickle cell. So it's not a parent's responsibility there. So it's taken out of your hands. It's public health we're talking about now. It's not individuals or families. It's government responsibility. So we're calling out
should be done by the government.
Exactly.
Okay.
So even if it's not totally free, it should be free, quite frankly. That's what we're pushing for. And people that are legislating for sickle cell, this is where the legislation should be. The legislation should be that government should ensure that newborn screening is carried out and it is free. It should also add treatment should be free for children under the age of 5. I think that's is worked in certain countries. I want to apply the same here.
Okay.
So the tertiary is when there are now severe complications that have set in, like stroke.
Which could start as early as 2 years old.
Yes. Okay. Once stroke has happened, it's really bad. So you need to rehabilitate that child. That's the third level of prevention, so that they do not get to a point where they're useless to themselves and useless to society. So stroke is an example. There's also the hip replacement that we do when they have degeneration of the hip joint. That tends to keep them wheelchair bound, and that doesn't help. So once that happens, rehabilitation is replacement of that hip joint through surgery. That's the kind of thing we want government to also step in and say, let's legislate and be sure that government provides this free. There's a long list. We have almost 500 persons waiting for that surgery. We have a relationship with orthopedic hospital in Nairobi, where they do it for us, but we go cap in hand asking for money. It's 2 million naira for one hip, and it tends to happen to both hips. So it's not what we can do on our own as an NGO. Government should step in, and if it is low, then that's. But it's not all of them who have sickle cell who end up with hip degeneration. But if it happens, let government help them with surgery. Okay, so that's another public health aspect. It's not, and then there are other principles to talk about public-private partnership. There are strategies that people can adopt for managing conditions. What is the private sector doing? Are they working with government? Those are strategies we need to look at to take care of the population in terms of sickle cell. There's also what we call multi-sectoral collaboration. This is something we can pick up from the HIV and AIDS space. It has worked perfectly for HIV and AIDS, where all the sectors work together. We don't look at it as just health. Education is involved, all sectors are involved. Here, for instance, I talk a lot about education using a stroke as an example. There's sometimes that stroke is not florid. It's not the paralysis that you notice. It may just be like I mentioned, I think, here on this program, that the child's handwriting has changed. And it's the teacher that sees it first. So there's need to work together with the education sector, health sector, and all the sectors. So that collaboration is also something that government should do and articulate in their policy. So you see, it goes beyond what individuals or families can do on their own. So that we've talked through primordial, primary, secondary, and tertiary. So there are different levels of prevention. That's how to manage sickle cell in the population.
Okay. And on that note, we wrap up the show.
We've spilled into the next
yes,
half hour.
Yes, we have, and we honestly have to go. We thank you for those of you who actually try to call in, but we just thought that yes, the information that Dr. Akinsete was trying to pass was most important, and we express our appreciation. Thank you so very much.
Thank you.
It's good to see you again.
Thank you. Good to see you, Thelma.
Yes. Join us same time next week for another episode of Surviving Sickle Cell, a show in partnership with the Sickle Cell Foundation Nigeria, located in Diaraba, Surulere of Lagos, opposite Luce. Am I right?
Yes.
Yes.
Lagos University Teaching Hospital.
Yes. And on our side, it's a show in memory of our blessed Tosi Bucknell. We sing her soul rest in peace. It's a beautiful Saturday afternoon. Go out and show some love to someone out there. I'll leave you with this one.